Thank you very much. Now I'll introduce Professor Fawaz El Refaee, consultant of pediatric gastroenterology at Aden Hospital. We'll talk about clinical approach to functional GI disorders.
مساء الخير عليكم جميعا. My name is Dr. Fawaz El Refaee from Kuwait, consultant pediatric gastroenterologist. أتقدم بالشكر الجزيل للدكتورة بروفيسورة مي نصار وبروفيسور إيهاب خيري على الدعوة الكريمة والorganizing committee. I wish all the best for this congress. I will talk about functional GI disease in infants, myths and realities. طبعا this is a very important position paper you can refer to, Middle East Consensus Statement on Diagnosis and Management of Functional GI Disease below the age of 1 year. This was published a number of years ago and it's available online for free. Also, this is a practical algorithm for managing common GI symptoms in infants, published in 2014 by Dr. Van den Plas. Why we care about functional GI disease? Because of the immediate impact of functional GI disease on stress, quality of life in the family, feeding problems, and health economic burden. And if we want to take a snapshot about the age of presentation of functional GI disease in pediatrics, the three common functional GI diseases start with infant regurgitation, followed by colic, dyschezia, functional constipation, lactose intolerance, and in older children, irritable bowel syndrome and cyclic vomiting syndrome. So I'll start with a clinical case. Ahmed, 3-week-old infant, birth weight 3.2 kilos, current weight 3.6. He started on standard cow's milk infant formula. He takes about 120 ml for 25 minutes, 6 to 7 times a day. He does not always empty this bottle, sometimes regurgitate or vomit. And mother consults because of the day and night crying, and she is desperate. Very common scenario, we see it in practice. And these are the key questions we have. Regurgitation frequency and quantity. We have to ask about the formula preparation, consistency and frequency of stooling, is he constipated, diarrhea or not, sleep pattern, warning signals present or red flags or not. And these are common questions we get about regurgitation as healthcare providers. How much spitting up is too much? Is it 3, 4 times or more? What can be done if regurgitation happens in breastfed baby? And my baby seemed to be spitting almost all of his feeds. What can I do? The good news here that with gastroesophageal reflux, which is a physiological phenomena, most of the time these children and infants will get better after 6 to 12 months of age. So if you look at the graph from different studies, by the end of first year, the frequency of regurgitation almost disappearing. And what are the red flags for regurgitation? These are very important slide for us to know. If the onset of vomiting started after 6 months, with the consistency of forceful vomiting, you have to think about obstruction or anatomical abnormality, bilious vomiting, hematemesis, failure to thrive, hepatosplenomegaly, bulging fontanelle, denoting that you have raised intracranial pressure, macro or microcephaly. And what about, signs of complicated GERD, gastroesophageal reflux disease, and this is very serious, and you need to refer these children for a specialist opinion to gastroenterologist. Sometimes happen in the GI tract. When the feeding problem happen, it might implicate esophagitis. Dysphagia can indicate strictures, heartburn, chest pain with erosive esophagitis and Barrett's esophagus if left untreated. And then with respiratory problem, with wheezing, recurrent chest infection, stridor, cough, you have to be careful with this, and this implicate that you have a complicated gastroesophageal reflux. Neurological with rumination behavior, ALTI or BRU, apparent life-threatening event, and also irritability, weight loss or poor weight gain. It can indicate significant medical problem. You're finding with Ahmed that formula was prepped correctly. Ahmed is very irritable during feeding. He stops frequently and arches his back. It's difficult to burp.
and he passed 2 to 3 bowel movements every day, normal consistency, had disturbed sleep and no red flags. So the diagnosis, what's your diagnosis here? It's very common from the history and physical exam. This is functional regurgitation. And here you know how to differentiate physiological from pathological definition of gastroesophageal reflux from gastroesophageal reflux disease. Gastroesophageal reflux is the physiological passage of gastric content into the esophagus. When you get disease or complication from the passage of gastric contents from the stomach into the esophagus, you call it GERD. And then you get a gray zone in between with colic or irritability or feeding problem or respiratory problem or back arching. And why, infants below the age of 6 months regurgitate? Basically, because of the gravity effect, short esophagus, supine positioning, and angle of his, this is underdeveloped. This is why, and you get inadequate gastric accommodation. All these factors contribute to transient relaxation of lower esophageal sphincter and functional regurgitation as a result. So what's your first-line management for functional regurgitation? Small feeds more often, or medication like sodium alginate, PPI, or antacid, parental reassurance with change to hydrolyzed formula, or parental reassurance with change to thickened formula. And the answer is A and D. You get small frequent feeding and change to AR formula. And based on the evidence, which management approach to regurgitation should you select? You start with nutritional management and parental reassurance, or pharmacotherapy. And again, it's a common sense answer. You go with A, because nutritional management and non-pharmacological approach with reassurance is always the first line treatment for functional GI disease. And what do the guidelines say? So the guidelines from SPGAN, NASPGAN, a Middle East expert group, also stressing the importance of review the feeding techniques and volume, thickened formula, and the use of AR formula to reduce the frequency and number of vomiting. Formula can decrease regurgitation in healthy infants, and there is little direct evidence to support the efficacy of frequent, smaller feeding schedule. Regurgitation is not a reason to stop breastfeeding. This is very important. And if you look at the composition of AR formula, we have to understand that not all thickened agents are created equal. Locust bean gum has been used widely now in AR formula and has the advantage of reduce the number of infants with regurgitation and episodes of regurgitation per day. Cereal, it has more calories, so you have to be aware of the obesity risk when you use cereal as anti-regurgitation material. Medications, are they effective in the management of regurgitation? Simple answer is no. PPI, we don't use it to treat colic or to treat irritability or to treat functional regurgitation, period. PPI have clear indications to treat peptic ulcer disease, bleeding. You can use it in the treatment of H. pylori eradication, and the specific courses on treatment with defined duration with weaning place, with weaning plane in place. When you get, a PPI, we don't use it to reduce reflux symptoms in infants or decrease infant crying or irritability. So systematic review of many RCTs in infants tell you that PPI are useless for crying irritable baby and for colicky or infants with functional regurgitation. What do the guidelines say about pharmacotherapy? So multiple RCT show lack of benefit on the use of PPI in infants with regurgitation or those suspected of having GERD. Even GERD, the evidence is very poor regarding PPI use. PPI treatment does not decrease infant regurgitation, and there is no indication for drug treatment for happy spitters or infants without troublesome regurgitation. This is just, coming from Rome 4 criteria that was published in 2016. And look at infants between week 3 and 12 months of age with regurgitation 2 or more times a day for at least 3 weeks. And history and physical examination, if you have red flags, you refer them to gastroenterologist for further evaluation. If they have no red flags, you treat them with parental reassurance and nutritional management. Shifting to Fahad, 2-month-old baby born by C-section at 37 weeks of gestation. Birth weight was 3.1 kilo, current weight is 4.85, exclusively breastfed, rectal temperature 37.7, looks healthy with no warning signals. Recurrent periods of crying and irritability that cannot be resolved by the mother and last between 90 to 150 minutes. More in the evening. And the mother tried carrying, burping, and shaking the baby with no effect. Very classical scenario for infantile colic. This is his growth parameter. He has been growing both in length and weight appropriately for his age. And these are common questions about infantile colic we encounter as gastroenterologist or as pediatrician. Why my baby will not stop crying? There must be something wrong with the baby. What can I do to stop the baby from crying? What is your diagnosis? We mentioned it's infantile colic. What's your first line of management for this child? Is it A, B, C, D, or E? He gets more frequent feeding, anti-colic medication. You give acid suppression, parental reassurance and change to hydrolyzed formula, parental assurance and change to formula for colic. And the answer here is D. And what do the guidelines say about the first line management? Again, for a lot of these functional GI disorder, almost all of them, education and reassurance is the first line of management. What do the guidelines say about the first line treatment? If you have, provide information on signs of hunger and fatigue, you have to look at the family structure and regularity and routine of the family, and self-limiting nature of the condition should be explained that things will get better in a few weeks to months for the family. At this point, there is insufficient evidence to systematically recommend swaddling and other caregiver interventions, herbal medicine products like fennel or peppermint, because the amount and the volume of the herbal medication to be used is huge, exceeding 500 mils a day to produce a positive effect. And this is exceeding, the limitation of the infant, because you need to provide them with calories from milk, either breastfeeding or formula fed. What about dietary management option and when to suspect cow's milk protein allergy in a patient presenting with colic? So infantile colic could be the first clinical manifestation of atopic disease and cow's milk protein allergy. You should think about it and put it in your differential diagnosis when you get a personal or family history of atopy or food allergy, or when you present or the infant is presenting with other symptoms like reflux, constipation, diarrhea, vomiting, or faltering growth. At this point, you can offer the infant and the family a 2 to 4 weeks trial of cow's milk free diet for breastfeeding mother, or hypoallergenic formula with extensively hydrolyzed formula, or amino acid based formula for bottle fed baby. What do the guidelines say about the breastfed baby? Trial of dairy products exclusion by the mother for 2 to 4 weeks trial, and insufficient data to recommend lactobacillus reuteri, although this has been looked at many RCTs with the specific strain of DSM-4 17938. Formula fed baby, you can try extensively hydrolyzed formula that contains prebiotic and ferments, lactose reduced or free formula, but again, the evidence is very inadequate to recommend all those and interventions unless you have evidence of cow's milk protein allergy where you can offer extensively hydrolyzed formula. This is coming from Canadian Pediatric Society statement about using probiotics in pediatric population. This was published in 2015. And again from two RCTs published 2010 and 2007 by Savino et al. Demonstrate that if you use lactobacillus reuteri with a specific strain for 3 weeks, there is a significant, clinically significant reduction in crying time for almost 1 hour between the probiotic group and the placebo group. So bottom line, for other pharmacological intervention for colic, that all these are not working in real life. Anticholinergic drugs like dicyclomine, because of the effect of cardiovascular system with tachycardia, arrhythmia, hypertension, gripe water. We don't have RCTs to support its use. Simethicone. Also, RCTs are of insufficient quality to draw conclusion, and PPI are not effective and the safety concern still about its use in colicky baby. So pharmacological therapy like PPI, simethicone is not effective, and some of them can cause serious adverse events. And the Rome Foundation do not mention pharmacological therapy for the management of infantile colic. And this is also from Rome 4 criteria. Infant less than 5 months with recurrent prolonged episodes of crying, fussing, irritability that occur without a reason and cannot be prevented or resolved by caregivers. With history of physical examination, if you get any red flags, you refer them immediately or treat the underlying cause. If not, you give parental education. Third case is Ali, 3-month-old male infant born at term with birth weight of 3.3 kilos, presented with infrequent hard stools once every 5 days since the age of 1 month, past meconium in the first 24 hours of life. He's bottle fed since birth, no other symptoms, normal growth and development, and normal examination. These are common questions with constipation. What changes to diet can I help to relieve my baby's constipation? Is fiber or fluid intake important? First of all, we have to understand that chronic constipation is a very common condition affecting 3% of outpatient pediatric visit and up to 1/4 of gastroenterology referrals coming with constipation in infants and in older children. And constipation is a symptom. It's not a disease by itself. With decreased bowel habits, hard lumpy stool, painful bowel movements, increased straining, bloating, distension, sensation of incomplete evacuation, infrequent stooling, stool every 5 to 7 days, and full rectum. All these denoting that the child is having constipation. You have to be very specific and careful when you obtain history and perform physical examination, and to differentiate infant constipation from dyschezia. Dyschezia is a normal physiological phenomena happen when the infant have incoordination between increased intra-abdominal pressure and relaxation of pelvic floor muscles. They are irritable, they have 10 minutes of straining and crying and pulling up their legs, and the face become red and congested and purple in color before successful passage of soft stools. Again, soft stools, they don't have constipation, they don't have hard stools. Treatment is reassurance. It will get better in a few months. Usually after 1 year of age, it gets better. Don't give laxatives. Red flags for constipation, of course, fever, vomiting, bloody stool, failure to thrive, tight empty rectum with presence of palpable abdominal fecal mass to rule out Hirschsprung disease, abnormal neurological examination, failed management with appropriate standard intervention with good compliance. All these are red flags, and you need to investigate and refer these children to gastroenterologist. So which of the following is not an organic cause of constipation? 95% of constipation in infants and children is functional, except 5%. So which of the following is not organic cause of constipation? Is it hyperkalemia, hypothyroidism, hypokalemia, lead poisoning? And the answer is hyperkalemia. Give you diarrhea, does it give you constipation? Treatment of constipation, you have to clean them out with disimpaction, and you give maintenance therapy for at least 1 to 2 months till adequate response is obtained, and then you do weaning for the treatment. These are common agents we use in babies. In babies, we use lactose, 1 to 3 ml per kg per day in 2 divided doses. In older children, 6 months and above, we prefer to use polyethylene glycol 3350 with or without electrolytes. I prefer without electrolytes because the taste is better, and the dose usually from 0.5 to 1 gram per kg per day. Other agents with stimulants, we can combine them for severe cases. Why pediatrician is struggling with the management of constipation? Because of inadequate doses of laxative, ignore the maintenance treatment, extensive workup without looking at the functional nature of this disorder, and don't overcome the helplessness and lack of follow-up. And again, you know, if you get 2 or fewer defecation per week in infants less than 6 months of age, you do your history physical examination. If there are red flags, you refer them to a specialist. If there are no red flags and they're exclusively breastfed, you know, you label them as functional constipation. This is last case, Aya, 5-month-old infant present with a prolonged watery diarrhea after acute gastroenteritis, lasting for 3 weeks now, and she's formula fed. Normal growth and development, normal examination apart from excoriated perianal area, normal labs, what to do next. So picture of lactose intolerance. Lactose is a disaccharide. It's composed of glucose and galactose. When it's fermented in the colon, this results in excessive gas production with hydrogen, methane, organic acid, and this will lead to, you know, osmotic load in the colon, leading to watery diarrhea, abdominal colic, distension, foul-smelling flatulence. So the question, all of the following are causes of secondary, not primary, lactose intolerance, except is it celiac disease, post gastroenteritis, GERD infection, cow's milk protein allergy, or adult type hypolactasia? Adult type hypolactasia, this is a primary phenomena, you know, and usually this is a physiological phenomena when you get a decline of lactase level with time. Once you are 5 or 6 years, you get a physiological decline in lactase level, and this is a primary hypolactasia. So this is with secondary lactase deficiency when you get, you know, villus atrophy, and you get, you know, after gastroenteritis, a lactase deficiency. This is a clinical picture of lactose intolerance, lactose malabsorption. This result as a pH reduction, become acidic, and become irritation of the perianal area. You can check stool pH, you can check reducing substance in the stools, but the ideal test is hydrogen breath test. And, you know, intestinal biopsy, this is a research method where you can measure disaccharidase assay enzyme levels in the duodenal biopsies. Also very important slide to differentiate gastrointestinal cow's milk protein allergy and lactose malabsorption. We have to understand that cow's milk protein allergy is a multi-system involvement with GI tract, respiratory tract, and the skin on the top, where lactose intolerance or malabsorption is confined to the GI tract. This is why with lactose intolerance, you get diarrhea, you get excoriated of the bum or bottom area, and you get, you know, poor weight gain, you know, rarely. As compared to GI cow's milk protein allergy, when you get failure to thrive, eczema, respiratory symptoms, rectal bleeding, diarrhea, or vomiting. So multi-system involvement in cow's milk protein allergy, whereas isolated GI involvement with lactose intolerance. So in conclusion, functional GI disease are common during first year of life. Accurate and complete history and physical examination is crucial. Reassurance and parental education is the cornerstone of management. These are my references, and thank you very much for your attention.